going to talk to you about logistics of newborn screening, and also a little bit about the justification for the notion of doing universal eye screening. We're going to talk about ROP, retinopathy of prematurity, as well as newborn eye screening. So here we have an image of retinal hemorrhages in a newborn, and that's going to be one of the things that we're going to talk about. And on the other side, we have a schematic of some of the ways that telemedicine can be carried out. We do receive consulting fees from VisuNex in terms of financial disclosures. So, what is telemedicine and teleophthalmology, and how does it pertain to newborns and to retinopathy of prematurity? Well, over here on the right-hand side of the screen, you have sort of like your central reading center. That could be you as the physician, it could be your team of readers, or it could just be the place where you have all of your computing infrastructure. And then you have multiple sites. Maybe it's just one site that you're capturing images from, or it could be a series of sites where these images are obtained and then fed back to sort of the central reading center. And that's what's sort of depicted there on the right-hand side. Now, this doesn't happen in real time. It's not like ophthalmologists are just sitting and waiting for these images to show up. So a lot of telemedicine occurs through what we call the store and forward technique of telemedicine. Basically what that means is that the images are obtained and then they're stored either locally on a hard drive or centrally in a cloud-based system with encryption to prevent release of protected health information. Then at a later time, maybe later that day, maybe 30 minutes later, maybe a few hours later, maybe the next day, a reader, trained reader or a physician will then log into the system, download the images, and then grade them through whatever mechanism is necessary. That mechanism may be so simple as a binary response. It could be normal, abnormal. It could be that simple. And if it's normal, no further action is necessary. If it's abnormal, then someone else either has to take a closer look at those images or refer the patient for an in-person examination to figure out what's going on, speak with the family members, etc. Then there could be other grading systems where we're actually grading the level of the retinopathy or the level of the pathology, but you can make it how you want it, and you have to set up that network in the way that you want it. And all those images can be accessed remotely, and as we're going to see on this next slide, that the images are residing in the cloud, as you see here in the center. That's one of the ways to do it, and it's really the easiest way because everyone has access to the images. You don't have to wait for the computer hard drive to get back to where it is that you can access it. And everyone can access it any time of day. Only those with the proper credentials can access it. But nowadays, with image compression algorithms and with high bandwidth networks, we're able to view these not just on traditional desktops with large screen, high definition DICOM monitors, but also through typical mobile technology that we're used to, such as iPad, iPhone-like interfaces. We can even print these out right from, for example, the PanoCam unit itself, or from your own printer if you wish to store it in a paper medical record. And so this is one of the ways that teleophthalmology has been used in retinopathy of prematurity for those that are using it now, but also in a way that we might be using teleophthalmology moving forward should we do universal screening as we anticipate doing. This is not without barriers. Number one, this is not something that people are used to. People are used to going to the neonatal intensive care unit, examining babies with the binocular indirect ophthalmoscope, making their drawings, putting that information into the paper or electronic chart, and then carrying on that way. But that's difficult to do. We're all busy, and it's really unnecessary. We can get much better information by actually taking a photograph of the patient serially over time if we need to, and it's very easy to go back and compare images as opposed to comparing drawings done by one physician on one day and another physician on another day. But as I said, it's not without its barriers. One of the problems that we have is if we're talking about doing this here in the United States, we can't have a doctor in Florida looking at images of a baby who's in a hospital in Texas and not have that Florida doctor be licensed in both locales. So that's a bit of an issue. It's kind of a murky area of healthcare law, but right now the recommendation is that you should be credentialed in both of those localities and oftentimes have actually hospital privileges at whatever location that the hospital where the baby is located. You also have to make sure that your malpractice insurer knows what you're doing, because you may be covered for retinopathy of prematurity screening or even universal newborn screening, but they may not know the complexity of how you're doing it through a telemedicine network. So at the very least, you need to check in with your malpractice insurer to make sure that they're aware of it. And then if there is a problem with the patient, you need to have an agreement in place with that neonatal intensive care unit, the neonatal doctors, so that if there's a problem, you have someone you can send that patient to. If you say, well, this patient has referral warranted retinopathy of prematurity, you can't just say that and then not do anything. That there has to be a place locally for that patient to go. And you just need to get those logistics in place in order to make that happen. So these are all sort of administrative and legal issues, but there's also obviously financial concerns. You want to make sure that you're appropriately getting compensated for the work that you're providing, and that's a separate lecture in and of itself. From a hardware issue, we talked a little bit about that in the preceding slides, but basically, you need to have the proper hardware to make sure that you're protecting personal health information, make sure that your software cloud server is appropriate, and have high bandwidth connectivity and backup. You can't be losing images. It's difficult enough to have the neonatal intensive care unit allow us to do these images when we need to do them. We don't want to repeat them just because you've lost the image. So you need to make sure that you have strong fidelity of your hardware system. So how has telemedicine been used in newborn ophthalmology previously? Well, my brother actually at Stanford University set up the Stanford University Network for the Diagnosis of Retinopathy of Prematurity, also known as the Sundrop Network. And basically, this was his way of performing lots of ROP screenings at many different hospitals simultaneously, obviating the need for him to actually physically go to these locations. So he had several hospitals in the San Francisco Bay Area where he had trained the nursing staff in how to use RetCam screening of newborn babies who are at risk for developing retinopathy of prematurity. And they had sort of the same imaging guidelines as we did for when we were examining these babies in person. And this was based on some of the early success of the PhotoROP study out of the Royal Oak group and previous Sundrop work. And this is something that's advocated by our societies that as an alternative way of performing newborn screening. This is something that's going to become more and more acceptable with time as a substitute for it, but we're trying to change ingrained modes of thought, and that's going to take some more time. And again, multiple studies have validated the use of telemedicine for retinopathy of prematurity screening, but retinopathy of prematurity, fortunately, is not as common of a problem as some of the other diseases that can present in newborn babies. We talk about childhood vision impairment in the United States, and one of the biggest problems that we have, not just for vision, but for childhood health wellness in general, is amblyopia. Amblyopia is exceedingly common. When you think about 2 to 4 out of every 100 babies eventually developing amblyopia during their development, it's a lot of babies. It's actually the #1 childhood disability, and it's the 4th most common disability overall. It's the #1 cause of unilateral vision loss in patients less than 40 years of age. So with that as our background, you would think that we were performing eye exams to look for things that might be leading to amblyopia earlier than age 6. But in fact, that is not a mandate here in the US. And even at age 6, we're not performing eye exams. What we're performing are vision screening. We only do eye exams if they fail the vision screening. But we would posit that that's perhaps inappropriate given the exceedingly high rate of amblyopia that's present. Maybe we're going to be able to uncover vision-threatening causes of loss of vision. So we don't actually do eye exams here in the US. And we think that primary prevention is better than dealing with trying to treat a problem after it already has presented itself. So newborn eye screening is a form of secondary or tertiary prevention. So we can find things like retinal hemorrhage, cataract, familial exudative vitreoretinopathy, potentially high mortality conditions like retinoblastoma, and other retinal vascular diseases like Coats disease or persistent fetal vasculature by doing newborn eye screening on all babies. And it's not just the fundus, as you'll see in a few images. We're going to capture external images as well. But some of the things that we can pick up in newborns are vitreous hemorrhage, macular hemorrhage, persistent fetal vasculature, and retinoblastoma. So as it turns out, in the few studies that have been done on universal newborn eye screening, not on premature babies, but just healthy newborn babies, is that they range somewhere between 10 and 20% of all healthy newborn babies. We see retinal hemorrhages. Now we can see sort of moderate intraretinal hemorrhages and subretinal hemorrhages like we see in this patient, or we can see more severe ones. And when we look at all retinal hemorrhages in newborns, 10% overall, or 20% overall have them, but about 2% of them actually have foveal hemorrhages. And it's felt that even transient foveal hemorrhages during the critical first few weeks and months of life can actually be one of the things that leads to unexplained amblyopia later on. And it's interesting that the rate of amblyopia is somewhere between 2 and 4%, and the rate of foveal hemorrhages across multiple different studies in different socioeconomic and demographic groups is also about 2%. So I'm sure there's no coincidence there. Now, interestingly, when we have occlusive disease, whether that's cataract, whether that's vitreous hemorrhage, whether that's foveal hemorrhage, not so much the disease itself, but the occlusion of the fovea, for some strange reason, leads to progressive myopia and possibly anisometropic amblyopia, where we have different corrections in each eye. And you can have occlusive hemorrhage that can lead to, just 3 to 4 weeks in duration, that can lead to high degrees of myopia, like -11, -12 diopters. And we know that anatomy oftentimes predicts function, and amblyopia can occur as early as 4 to 12 weeks after monocular visual deprivation. And as we said earlier, we can see that myopia often follows hemorrhage. So what does newborn eye screen testing look like? Well, this is the type of image that a reader would see. So we have an external beam showing what the outside of the eye looks like on both sides. And we also recommend doing the two eyes together so we can kind of see what the baby looks like in general. Then we do an optic nerve centered image. And then we can look at the inferior and superior retina, the peripheral, nasal, and temporal retina as well. And this is with the contact-based system, whether it be the RedCam or whether it be the PanoCam or some other device. These are the type of images that would be captured in a standardized manner from every baby. And this is not with the doctor taking these images, it would be with a trained image acquirer. I suppose you could call them a photographer. But here it could be a medical technician, it could be a nurse on the unit. So again, we get fundus and external images, trained readers, could be physicians or it could be people who you train how to systematically interpret these images, again, using some of the techniques we talked about earlier. So at Stanford, they're already doing, in addition to the Sundrop thing, they're already doing universal newborn eye screening testing in a pilot program they call NEST for newborn eye screen testing. They have this brochure that sort of explains to the families why it is that they're doing it, what they're looking for, and what happens if we uncover an abnormality. And again, sort of patient information for the family. And what have they found after the first year? Well, out of the first 203 patients that they have follow-up on, again, this same consistent number keeps showing up. 20% out of these 200 otherwise healthy newborn babies have retinal hemorrhages. Here's a representative example. This represented 16% of all eyes, with some patients having bilaterality to these retinal hemorrhages. And about, again, not 2%, but close to 3% of them had foveal hemorrhages. Now you have foveal hemorrhages and you have foveal hemorrhages. They're not all going to be the same degree of severity, but still, any hemorrhage in the fovea, at the very least, is going to require a follow-up examination, simply just to make sure that it clears in a timely manner. If it doesn't, then intervention may be required, but that would not really be the role of the telemedicine physician. It's the role of the ultimate physician treating the patient. Here's examples of some of the hemorrhages that were acquired. This patient had significant asymmetry from one eye to the other, with lots and lots of retinal hemorrhages, almost like an essential retinal vein occlusion-like pattern in the left eye, but almost none in the right eye. Again, another example of asymmetry. Severity of the hemorrhages, you get some Roth spots in this patient with white-centered hemorrhages as well. The million-dollar question is, why do they have these hemorrhages? If they're healthy, they're not premature babies. We don't really know. We have lots of hypotheses about why it might be the case. There's some evidence to suggest that vaginal delivery is more likely to be associated with retinal hemorrhages, with longer labor in terms of hours, versus a cesarean section where they're not going to have that birth canal trauma for hours on end. But we don't really know. But it's something that needs to be figured out. So what about the timing of the hemorrhages? Well, we know with newborn premature babies, we don't examine them right when they're born. They have enough going on that the eyes are sort of the least of their problems. We need to make sure these babies stay alive. And that's one reason why we don't examine them right away. The second reason is we don't anticipate finding retinopathy of prematurity until somewhere between 4 and 7 weeks of life. And so we don't examine them until that time frame. However, with newborn eye screening, and this is typically around 31 weeks, if a baby was a 24, 25, 26 week gestational age. However, for newborns that are not premature, we would recommend doing it at term within the first 24 to 72 hours of life. And the main reason for that is they're still in the hospital. Once that patient goes home from the hospital, you're really going to have a very difficult time to get them back in to get a dilated eye exam, well, with even the least invasive technology. And so if we can get that in along with their newborn hearing test, that would be extremely helpful. So when we look at our experience with term birth versus premature babies, only 1.7% of the premature babies have retinal hemorrhages compared to 20% of the full-term babies. Kind of sounds counterintuitive. Why would that be? Well, turns out when we go back to those other studies from Brazil and China and other places, and we see what happens to those babies that did have hemorrhages, that they tend to resolve within about 4 weeks. We're not examining these premature babies until about 4, 5, 6 weeks of age. So by then, if they did have a hemorrhage, it likely resolved. So we're sort of missing the hemorrhage in those babies. We're examining them much sooner, and that's likely why we're missing them. And again, we're not really looking for hemorrhages, we're looking for ROP, which presents not only posteriorly but peripherally in the ROP babies. So one of the implications here is that for newborns, we're going to recommend, if that newborn screening be done in the first 48 to 72 hours, to make sure that we're capturing these hemorrhages, to make sure that we're getting a high denominator. We want to make sure that we're getting these babies before they go home with their mom. So the NEST study was then expanded into the GUEST study, which is global universal eye screening, not just in California, but in multiple countries as shown here, to try to get a bigger denominator. And this is something that's going on underway. And here's an example of the type of telemedicine interface that you might have if you're the physician who's logging in and reading these babies. So you click on the images, you see the type of images that were captured for that baby, and you can just click on the different ones and see what you would like. And we're also working on algorithms to create a montage where, in addition to the individual images, you might be able to see them assembled all together. And here's an external image of the baby, and then you would make your adjudication whether that's normal, abnormal, and then move on to the next patient. And also we're capturing eye color as well. All right. So right now, this is being carried out using multiple screening protocols in many different countries, and so far they've captured close to 90,000 images. Keep in mind, we're doing about 6 to 7 images per baby per examination. And this has been done in about 5,700 patients throughout the world. They're using certified graders, and these graders consist not just of a, let's say, retina specialist experienced in pediatric retinal disease, but also pediatric ophthalmologists, general retina specialists, general ophthalmologists, fellows, pediatric ophthalmology and retina fellows, residents, medical students, and even further down the line, nurses and technicians. Once the proof of concept comes out with sort of the gold standard graders consisting of your pediatric ophthalmologists, your retina specialists, and so on, ideally we would like to have certified graders who are perhaps a little bit less expensive than those enumerated at the top of the screen, but still with a high degree of consistency and repeatability of their grading, high degree of accuracy. So what the guest data is still being collected, hasn't been reviewed yet, but as I said, they've got a ton of images so far, and they're going to be looking at interim data soon. But in summary, what we've talked about here today is some of the logistics and barriers to setting up a telemedicine network, and then some of the justification for why you would want to do it. One of the reasons, of course, is retinopathy of prematurity screening, and several doctors are doing that already, and some are doing it in a hybrid fashion, where they're using in-person examinations, they're supplementing that with fundus images. When we do newborn eye screening in the non-newborn ROP population, or the at-risk ROP population, what we found is that 20% of patients have hemorrhages of the retina, and somewhere between 2 and 3% of those tend to be hemorrhages that involve the fovea. Keeping in mind that amblyopia occurs in 2 to 4% of patients, even though these hemorrhages only last about a month, it's possible that in some of these patients they're lasting longer, and in some of the patients that may be one of the reasons why they're getting anisometropia, progressive myopia, and dense amblyopia due to this occlusive pathology. So if universal newborn eye screening is to be done, we recommend that it be done before the patient goes home in the first 48 to 72 hours. Another reason to do that is really medical legal from the patient's perspective also. There's a lot of talk about shaken baby syndrome and retinal hemorrhages. And if you have retinal hemorrhages documented at baseline before the baby leaves the hospital, and let's say the baby comes back in a month or two and now has stigmata of shaken baby syndrome, these baseline images may be helpful in adjudicating whether or not that's a real possibility. So I'd be happy to take any questions about barriers to newborn eye screening and ROP screening in general, and I'd be happy to talk to you about this new product as well as trying to implement this in your practice. Thank you.